Hello and welcome everybody to the session. Thanks for those of you that have dialed in today. I'm Anna Earnshaw and I'm the Chief Executive of West Northamptonshire Council, and I'm also the System Leader responsible for the iCAN programme, which we're going to be talking about in today's session. We're going to do 15 minutes very quickly, walk through an introduction to the programme, what it is, why we have it, how you can get involved. And that's key to us today. And then I'm going to hand over to David Mayer, who's then going to host a Q&A session with some of our clinicians and other people involved in the programme, and which I really hope that you'll get involved in and engage in. We will be done by 4 o'clock. Just to remind everybody, this is a Teams broadcast, so if you'd like to raise a question for the Q&A, please do write it in the chat functionality, which you can see on the right hand side of your screen, and you can access that chat by pressing on the icon that is the speech bubble at the top right of your screen. And depending how many questions we get, then we will do our very best to make sure that we can get through them in the Q&A, but if we can't, we will share answers on the website later. Next slide, please. And apologies in advance for doing the Chris Whitty next slide, but I'm afraid that's the best way. So just to recap, first of all, and go back to 2019 in May, when the Northamptonshire Care and Health and Care Partnership and Health Watch both jointly hosted a community engagement session to discuss some of our big ideas about care of the future. And we undertook a public survey and we listened to what you said your priorities were in terms of accessing health support, advice and the other services that we provide. And we know that since then, COVID has given us even more challenges to work with. But ultimately, what we see now is that the things you said then are the things that we still need to achieve. And this is what the programme is actually aimed at. The ideas of communities, person-centred cares and partnership are all absolutely key to what we're doing. And we want to work with you and across the system to make sure that we meet the needs of our population. Next slide, please. I think we all know it's a very, very challenging situation. You only need to look at the headlines and some of the things that are being said about the pressures on all of our services at the moment. And these are just a few of them on the screen that have been pulled just in November. And across the country and Northamptonshire, there is no exception to this. We're seeing workforce shortages, obviously the pressures and the fatigue, and an increased demand on our services. So absolutely vital we start to think about what we do differently. Next slide, please. If we look at our population, our demand for health and care is growing and very clearly growing. And you can see from this graph, which I know is a bit small, but it's absolutely growing, particularly in our ageing population. And we know that they are more likely to need services from us as we go forward and as we all age. So even without COVID, we know that we're heading towards a place that if we don't do something different, we're going to struggle to meet our population's needs in the way we want. And there is work now to focus on these different groups. And today we're talking particularly about iCAN, which is about the over 65 patient cohorts and frailty and the elderly. Next slide, please. So what will happen if we don't change? It's probably just worth touching on that because it's quite key. If we don't change, we can already look ahead at the population figures, and we know already that we would need 150 more GPs to be able to support the kind of demand that would be created. And whilst many of the population might say, well, that's great, we want more of those, it also means we'd have 10,000 more admissions a year to our hospitals. We'd need 550 more hospital beds, so in effect to build a new hospital. And we would also need £120,000 more to spend every single day. And the worst thing about it is that we know that right now the way we're doing things is not achieving what people tell us they want. We're not supporting people to stay in their own homes with their loved ones and in their communities, and we want to change this. And we want to deliver really high quality services that allow people to age well, stay well at home rather than getting ill and rather than spending unnecessary amounts of time in hospital. So I'm just going to hand over to Kim Curry quickly, who's just going to talk us through the sorts of patient experiences we're looking to address. So if you go to the next slide, please. Are you there, Kim?
Hello, can you hear me?
Yes, we can. Thank you.
Great stuff. Thank you. So you can obviously see on the screen there some of our patients, and the whole purpose of iCAN is that we know that they could have a better experience and we know that we can improve outcomes. We hear a lot from patients, and we hear from people like Mrs. A, who didn't want a package of care. She wanted to go home without one, to be in her own home, but that risk wasn't taken. She wasn't able to be discharged without one, so she accepted one just to cancel it the next day. And that's not a great experience for anybody. And it's also using very slim resources, as Anna's just alluded to in her slides. We also hear from carers, like Mrs D, who looks after her dad at home. He stopped taking his medication and his condition got worse. And because there wasn't the access to the right support at home, he ended up in hospital. Now, in an ideal world, the right home-based support would have been available to help to make sure that he was taking his medication correctly, and also that medication was being monitored well as well. We hear like people from Mr J, who was ready to go home from hospital on a Saturday, but because it was a Saturday, he was delayed 6 days waiting for a scan that he could actually have come back to hospital at a later date to have. So by having a much more connected and joined up health and care system, we want to improve outcomes for people so they're not having the experiences like the ones we've just described, which are all very real experiences for people.
Thank you, Kim. Can we go to the next slide, please? Thank you. So the key question is, how are we going to change? Well, there are 3 key things that we're looking on to underpin the work we're going to be doing with the over 65s. So the first is focusing on maximising independence and helping people to age well. And this is in line with what you've told us you want and also national direction. And what this means is increasing the chance for people to be able to stay well at home for longer, living, as I said, in their communities. We're also identifying what needs to change, listening to patients, working with clinicians and practitioners to make sure that this is a clinically led programme. We know that the public, tremendously trust that sort of health advice and that NHS badge. So we've got to make sure that we're all focusing on the outcomes for patients. And if the work we do doesn't help people to stay home or return home after being ill, then we really aren't getting it right. And finally, it's important it's system wide. We are working across councils, hospitals, community trusts, the clinicians, our commissioning group, the ambulance services and the voluntary sector, because we want to make sure we work together and we're fully committed as a system and as leaders across the system to doing it together, to helping staff set aside time to do this and to make sure we do it well together, thinking about the person at the centre of our care. Next slide, please. So that's how we're going to change, and iCAN is the transformation programme that's going to enable us to do that. What does iCAN stand for? Integrated Care Across Northamptonshire. It's a programme that focuses on the needs of people over 65 across the county. And we have a real focus on prevention and enabling people to stay well. And if people do need to come into hospital, ensuring they do get the treatment they need, and then they return home safely and as quickly as possible. Next slide, please. So what will that mean? So if we get it right, we think in 2025, these are the kinds of statements that people, residents will be able to make about the kind of care that they get and how they can be treated and have confidence in it. So just for example, I can return to independent living if it's all possible, and I expect not to have to return to hospital unless it's absolutely essential. So what our programme is about is making sure those statements are a reality in 2025 and that we get this right as a system. Next page, please. There's obviously a roadmap that sits behind this. That's absolutely key for us because we need to make sure that we have a clear path that everyone can see we're progressing to and that everybody can understand what steps we're taking and that they can hold us to account to make sure that we're moving in the right direction to achieve those things. Thank you. Next slide. So only a couple more and then we'll begin to the Q&A. So what's in iCAN? There are basically 3 key areas of it. The first is what we call community resilience, but basically that's about the support that we give older people in the community to maintain their independence and help them stay well. To do this, we need to carefully plan with all the services and make sure the support is there around GPs and around people to make sure that if something happens and they're not well, then we avoid their health getting worse. We'll provide people with services in the community which make sure that the right action can be taken at the right time to help them stay there and stay independent. And we'll make sure that if people go to hospital, then we have the support in place that can support them when they return, just while they get back on their feet. Community resilience is probably the key one for us that we know we need to grow, because if we do more of that, we'll avoid more people going into hospital unnecessarily and also make sure people stay well longer. So frailty, escalation and front door, but to you and I, what happens when you arrive at the hospital? So we want to make sure that people can, as we say, stay independent and healthy and happy as they become older. We know people slow down and get less resilient, and we know that actually we need to make sure we give them better information to make the right decisions. So this specialist team will support people who need help beyond that day-to-day, which could be provided by the community and GP surgeries. And these teams will make sure that people are treated swiftly and effectively so that they can get back to their normal life as soon as possible. They'll work alongside the community and the emergency departments and the ambulance service too, to make sure that all frontline health and social care workers also understand what support is available for a person who can be helped in the community before they actually end up presenting in hospital and being admitted. And finally, what we call flow and grip, which is all about when you're ready to go, how can we get you safely out in a timely manner? We know we want to reduce the amount of unnecessary time that people stay in hospital, and while many people sort of feel that it's a safe place to be, we know that people actually decline, and it doesn't always produce the best outcomes if you stay beyond the time that you need to in a hospital. So we want to improve that experience and make sure we get people out with the right information, the right support, and that we actually think about their care at the heart of everything we do. So we'll be working to make sure we maximise people's independence and return home happily and safely by connecting them to the hospital teams and also to the teams in the community. So next slide, please. So why have we not done this before? The conditions maybe have not been right to make this happen before, but we know that prevention is a real focus at national level, and there are things that are happening nationally now that really support what we're trying to achieve. The Ageing Well programme is there, and that's supporting the journey. And in the past, health and care have not probably worked as closely together as we could, but we're now confident that this programme will make a difference because we've given the commitment from system leaders to the clear vision, the intent and the investment to make it work. We have that clinical engagement and drive for improvement to make sure that everybody's buying into the decisions we make and how we work. We're learning from other systems about what's worked and what's not, and we have the momentum from COVID proving how the system can work effectively and make good decisions to help people. And final slide, please, before I hand over to David. So what will iCAN deliver in terms of outcomes? So very simply, these 6 key areas: more people able to stay at home, fewer admissions to hospital, more proactive support to stay well, easier access, larger focus on community services, and fewer patients delayed when they are ready to leave. So that's what it will look like. And for staff, there will be a bigger need for community services, and we will support better patient flow, which I hate as a word, but that means getting people to where they should be in a timely place and with fewer patients delayed and easier access to the community. So I hope that you agree that that's a really good aspiration for us to aim for. Next slide, please. So just in terms of how you can get involved and what's next, we will be running a series of these events and an Ageing Well as part of an Ageing Well festival, and we'll be launching something to build awareness around the programme. But most importantly, there will be a series of these events, and we also have a really vibrant People's Advisory Group made up of patients, carers and service users who will provide external assurance to the programme, because actually what we do and getting it right involves making sure you think that it works for you and it will give you the support you need, not just what we think is needed. We have to do this together, and that involvement and co-production is absolutely essential. Some of our initial work around the Dementia Community Asset Group development and the welfare support teams has already been co-produced and is really producing good things. And you'll be able to find out more about that and how to get involved in that group on our website, the iCAN website. So now I'm going to hand over to David, who is going to chair the Q&A session and our panel of people who've been involved in things to be able to answer your questions. So David, over to you. Thank you.
Thanks, Anna. Wow, it's such an exciting programme to be involved in, and particularly exciting to be here today to talk through some of the things it's trying to do with a panel of experts. What I'm not going to do is go around and ask them all to introduce themselves. We've got some questions that have been coming through, so I'm just going to pick out some of those questions and ask them to respond, and they'll introduce themselves when we do that. So I guess I was thinking as Anna was talking about the idiom of health being made at home and hospitals being for repair, and I was thinking about the importance of integrated care for people who are using services in that way, and particularly about community services and about their role in helping people live ordinary, independent lives. Paul, I wondered if you could answer one of the questions that we've had around some of the projects that are happening. So we've got some apps that are coming online for people that they can use, and some different innovations. I know, Tom, you might be able to talk about board rounds and different things happening in hospitals. So maybe to you, Paula, first. So you're able to say some of the work you're working on.
Hi, yeah, thank you. I'm Paula Love. I'm one of the lead nurses for the Integrated Care Transformation Programme, and I'm really excited. We've been working on My Health and Care app. It's an app that's designed, we've been co-producing it with members of the public. It's about to go live in its test. And the idea is that for Northamptonshire, you can put in certain conditions or things that you might be struggling with across health and social care and the voluntary sector, and it will guide you to what services are available. The other beauty of the app is that actually professionals that are out there not quite sure what services equally can use the app. So we're hoping that it will really support and enable people to get decisions quickly about where they need to go. It will give them the contact phone numbers, times of services that open. So it's really, really good. It will also, when it gets going, it will have some educational support on it as well. So we hope that it will be quite robust and quite resilient. One of the other programmes that we're working on is a programme called Get Up and Go. It's a programme that started before the pandemic with Public Health and Northamptonshire Sport, and we're working as a collaborative around this programme to provide an enhanced model where we're providing education around how to prevent falls, strength and balance exercises, so really helping people to improve their strength and stamina after a fall or if they're at risk of falls. So it's a really good programme. It's a project at the moment. We're getting feedback from the participants, but the outcomes already for those that have participated have been absolutely amazing.
Illustrates some of the value of co-production, doesn't it? Doing things with people, trialing things out, and then seeing the benefits that can be spread to others. On co-production, Tom, we've been doing some work with our clinicians too, haven't we, in terms of using board rounds differently to help people have their needs identified sooner and then get moved into a more independent pathway. Can you say some more about that?
Absolutely, yeah, thanks, David. So my name's Dr. Tom Evans. I am a GP, as it says at the beginning, but I'm a bit of an unusual GP, whereas I actually work for an acute hospital. I work at Northampton General Hospital. I've been in the county for the last 20-something odd years. That ages myself a little bit, and this is a really exciting time to be looking at how we can integrate all our cares together. So I lead on Flow and Grip, which is looking at how you can move through a hospital, how you can actually move through a hospital and be in the best condition that we can make you be in, and you can become in before we send you home. And one of those big areas we look at is actually how we plan and how we look at your health and your discharge before we even plan it. I know that doesn't seem to make sense, but the key thing is to have the communication within the hospital between the members of staff and yourselves as patients to be able to plan your discharge, to make sure that we know where you're going to go, where your expectations lie, what condition we can do to improve you in, and just to basically smooth line the processes inside the hospitals to make sure that your length of stay in the hospital is exactly what you need it to be. And the reason why we look at that is if you spend 10 days in hospital, and the evidence is that 10 days in hospital and you're over 85, your muscles actually age by more than 10 years. So if we can reduce that length of stay that you're in hospital for and give you exercises and your own care to be able to strengthen your muscles, then we'll get you out of hospital in the same condition before you became ill, before you came a crisis. So the board rounds is how we do work as a team to be able to guide and sort of, involve you in your own care planning and discharge planning to get you home as quick as we can. I hope that makes sense, David.
Yeah, no, it's helpful, Tom. And I wanted to explore a bit more the GP primary care side of things. I wondered if I could bring John in on this, particularly thinking about that interface with primary care, community services and hospital settings, and the particular role that primary care play in some of our integrated care work. John, have you got any perspectives or thoughts or anything that you're particularly excited about in terms of the iCAN programme?
Yeah, thank you, David. John Harris, I'm a GP. I've been a GP in Brackley for 28 years. I also set up and chair the federation that binds practices together in the area. I've got a foothold in hospital medicine, so I work as an endoscopist in the hospital. And I also are on the local medical committee. That's the executive that looks after GPs across Northamptonshire, and do one or two other things as well. For this, I'm the clinical lead for the first part of this iCAN project. That's the community resilience part, along with some others on this call. The really exciting thing for me about this whole project is that for the first time in my life, I can imagine that we will be able to develop a system in general practice stroke primary care that actually delivers for patients what I've wanted to deliver for them for all of my working life. In other words, when we have some needs in the community, the resources, the people, the expertise are there on tap in a way that is identifiable and accessible in a timely fashion, so that people can be looked after properly. And we do not get into the difficulty that we've all experienced in general practice over the years of struggling to find the care and resorting to admission to hospital, or to just saying, well, can you just hold on for a bit longer, see if your relatives can come up, and suboptimal care in the community. So for the first time in my working life, this is a massive opportunity to actually try and get this right in general practice stroke primary care. And I'm really excited for the opportunity to be involved in that.
Thanks, John. I think that if I could ask you all to begin to think about your top tips as we head into winter and some of the challenges around Omicron, that would be helpful. I might ask, we might go around and have some top tips from some of you in due course. But you talked about kind of involvement and co-creation of the work, really, and the importance of involving different stakeholders. And Mark, I wondered particularly about your role in the carers network, and indeed the voluntary sector more generally, and how critical a role they have to play in keeping people well and independent close to their homes. And maybe you could just say some words about the work you're doing with the carers network and the PAG.
Thanks, David. Yeah, so I'm Mark Major. I'm the CEO of Northamptonshire Carers, and I support the iCAN programme in a number of ways, as David said, through the People Advisory Group, and then also around things like dementia, befriending, and other work in the community resilience pillar. So I suppose the starting point is that, as you've heard, people are at the heart of what we want to do, and so involving people in what we do and hearing what they have to say and co-producing solutions is absolutely integral to this programme. And one thing that I hope is really coming across is just how passionate we all are about this, and how much we want to change things in the right way. And it's almost like we've got the 3 R's, I think, which is the right ambition, the right commitment, and the right partnerships. And now we need that 4th R, which is the right delivery, really. So I think, as David was alluding to, those partnerships between statutory, voluntary sector, patients and carers are absolutely integral to what we do. And we're already seeing some fantastic early successes in some of the areas that we've been working on, like dementia and befriending, and some of the stuff that Paula was mentioning. So we all feel this is absolutely the right way to go, and we're really committed to making it happen. Thanks,
Mark. And if people want to get involved in the People's Advisory Group, they can drop a note to any of the organisers here, and we can help make those links and those networks. So thank you for that. Anna mentioned earlier when she was introducing about social care and local authorities, and of course we're now in a really exciting place in Northamptonshire with 2 unitary authorities, a real opportunity to do some place-based work with communities in a really hands-on, granular way. And Sam, I wondered if you might be able to say, from your perspective, some of the role and contribution social care have to make in this world of integrated care.
Hi, thanks. So I'm Samantha Fitzgerald. I'm the Assistant Director for Northamptonshire Council, and I'm involved in iCAN in numerous of the bricks and pillars. So you're right, this is about health, social care and all of our wider stakeholders. So it's really important that everybody's at the table. So some of the things that we're doing in social care to deliver what needs to be done is if I listen to the work that John was saying around primary care, so we've put welfare support workers into our primary care networks. So that means that there's a direct link into those GP services, and what we do is we link those workers back into our locality based community teams. So there are social care teams working with people in a real strength based way, so looking at the assets that people have within their communities and their networks. And the idea around this is to keep people well and independent for longer by using those assets that are around them. So one of the things that we've been using at our disposal is very much around the use of reablement. So offering people that chance to have reablement, whether they're recovering from a hospital admission or whether it's around an avoidance, to really focus on people to get them independent as possible. So that's really fundamental. And then looking at when we were talking about length of stay and actually making sure that people only spend the optimum amount of time when necessary in one of our acute hospitals. There's been some real collaborative work done alongside our health partners and our acute colleagues, looking at, as Tom said, not only what happens within the acute, but planning for that discharge from the point of admission. So we focused that on some multidisciplinary teams, so a group of professionals really making sure that they're involving the person and their relatives in those decisions on where is the most appropriate place post hospital. And actually one of the main drivers that we've been trying to achieve is around home first. So looking at all opportunities to get somebody back to their home address, and that could be a collaborative approach of health and social care working together, working with our counterparts in the voluntary sector around making sure that people have got the most appropriate support. But ultimately also doing everything that we can to prevent admissions to residential and nursing placements, when actually we know that people do much better if they can return to their ordinary place of residence. So really about getting good outcomes for people, but more importantly at the right time and in the most timely way possible.
Yeah, it's hugely important. That focus on certainly what I heard from you, Sam, was that focus on patients and pathways, not organisations. That's what makes the iCAN programme distinctive, is that it's just focusing on bringing care together in the right place at the right time for our residents, and it doesn't need to be related to organisations necessarily. So that's really powerful. Thank you. I was having to think just some of the messages that were coming through on questions around mental health and the role of our mental health services in iCAN. And I wondered, Jean, if I could bring you in just to comment on some of the work you've done in primary care networks and other ways of bringing services around patients and focusing on pathways. Are you still on mute? I think that might be a technical issue our end. So leave that with us, Jean. We'll sort that out. I think somebody needs to free up the microphone. If I could bring perhaps Sheila in, just in terms of resident involvement and how there's some good examples at the start, wasn't there, about the power of patients and individuals testing out new services and then communicating that so that they can be embedded into other services. But can you tell us about your experience working with the programme and how you see the benefits of involvement playing out into service improvement?
Yes, I think perhaps you could call me an expert by experience, because I am one of those older people who I hope is ageing well. I've been a member of Healthwatch since 2013 and other organisations before that, and they asked me to be their representative on the people advisory group that Mark leads, and it's good to see all the different parts of the programme coming to us so that we can comment, perhaps just a few minor adjustments here and there. I was my husband's carer for 20 years, so I have quite a lot of experience of services in the community. Most of that time I was in Cornwall, where everything's much more distant than it is here. I also represent Health Watch on the Patient Experience Steering Group and the Safeguarding Steering Group at Kettering Hospital, so that gives me that link there. And on the East Northants Health and Wellbeing Forum, so I'm hearing about things that are happening in the community too. And it's good to involve yourself like that so that you can pass the information on. I report back to Health Watch and we take up any issues with the appropriate people and make suggestions in the right places and collaborate on these events that you plan. The one that was at the beginning, and I understand more coming from what I hear from our Health Watch manager. We do cooperate, and I'm slightly involved in the grip and flow bit because I'm working with a small group on what to actually put in the discharge booklet and the discharge letters that would be helpful and give the people the right contacts there.
That's really important work, and Anna mentioned in her presentation a festival next year that we're planning on pulling together, and I know you'll be pretty central to our work on that, Sheila, about thinking about different topics that we can use. Just thinking back to your point then, Sheila, that you made about outcomes and success. So what does success look like for the iCAN programme? How will we know that it's done something different for our residents? Maybe if I could bring Kim and then maybe Jean into that. So what are our outcome measures, Kim, and what does good look like?
So I think what good looks like will be entirely defined by people's experience. Going back to the slide that I talked on previously, it's not about us deciding what good looks like or what, and some of the wording we use doesn't help, does it? You know, we talk about suboptimal care or optimal care, and I'm as guilty of that as anybody. And what's important is that people have a good experience and that the outcomes that they choose for their life and their aspirations, as a bunch of professionals, we do as much to meet as we possibly can, and that we also help people to take risks. We may not agree with some of their decisions, but what we should be doing is helping people to manage that risk as safely as we possibly can, accepting that, you know, people have the absolute right to do that and live in most cases in the way that they choose. So I think what we've really got to get to grips with as a programme is to stop, not to stop, it's important that we count things, but we need to find a way to measure good experience. And that's where our patient advisory group and those people's voices across both West and North Northants are really important. So part of the work that we're going to be focusing on in the new year is to understand how we do that, how we really get to grips with experience and better outcomes that mean something to people, not just counting things that mean things to us as a bunch of professionals.
Can I add something there, please, David?
Sheila, do.
Yeah, I think the mistake that people often make is they don't think of older people as individuals. They tend to talk about them as older people. I hope I'm a good example of choosing well and living well and staying well. I have several ongoing conditions, including a peripheral neuropathy in my feet caused by nerve damage, and I'm prone to falls. But I've learned with help and advice how to manage that over the years. So it doesn't crop up unless I actually tell people.
Well, you're an inspiration, I think, to some of our communities that we're working with, Sheila, particularly when we're trying to think about falls prevention and ways of supporting people live independently and how we do that as a wider partnership. I know some parts of the country have involved the Fire Brigade, and I know Anna's been having discussions locally with the Fire Brigade about their involvement in the programme when they do health welfare checks on people to check that their living environment is safe. So that's a good prompt and a reminder of the power of partnership working, really.
Indeed, I used the full service regularly when my husband was alive, because I couldn't lift him when he fell. And if it was a Sunday, it wasn't the full service, it was the fire brigade who appeared with their fire engine, which amused all my neighbours.
You have some good friends in the fire brigade then, as a consequence, it sounds. But good that they were able to do that. There's a question come in just about access more generally, and I wondered if our primary care colleagues might be able to have, maybe I could bring you back in, John. Do you see iCAN having a benefit for people accessing primary care resources?
Yeah, one of the things that's started really well here is that in each of the areas of primary care in Northamptonshire, that's 16 of them around what's called PCNs, we have a frailty lead now, a doctor who's overseeing the development of a team that's integrated with each of the general practices in that area and with all these other service elements that you've heard about in this call. And each of those frailty groups has a manager to oversee the thing. And whilst that's in its infancy, the opportunity to do that and get really quick and easy access for patients to the services they really need. Forgive my patients line, I'm a doctor, so it's always patients rather than clients, but I really mean clients. That opportunity is there for the taking now, if we can construct this as we all hope we can achieve. So yes, access definitely is right at the front of the agenda for me in the community resilience elements of this work.
So hopefully, I mean, that's partially thinking about right care in the right place at the right time, isn't it? And that's partially what we're trying to achieve with the programme, is that, you know, care that's been given in hospitals, if it could be better placed in the community or with primary care, then we support that as a partnership, so we keep the system kind of able to function sustainably. Jean, I think we can bring you back in now, just to talk about, from your perspective, maybe just introduce yourself and iCAN through the lens of mental health and community services more generally.
Yeah, so I'm Jean Knight. I'm the Chief Operating Officer at Northamptonshire Healthcare Foundation Trust, and I, in conjunction with John, is the pillar lead for the community resilience pillar in iCAN. So we provide mental health and community services. I'm very proud to do so. I think one of the key things that we have learned from is in mental health, the key co-production principles that all of our work revolves around. So it's not just co-production with staff and with service users, but it's a genuine start with a blank piece of paper and build up in terms of how we can work collectively to ensure that our service users get the services that meet their needs. And that's absolutely something that we want to try and do within the iCAN piece of work as well. And we've seen it work in some of the areas that we've already started to develop and move forward. It's about a bottom-up approach. So John and I can't sit in a darkened room and decide what our population needs. It's got to be the population telling us what they need and us then designing our services around that. So that's one of the key things that we're trying to do, and hopefully these are the steps forward in terms of, this is the first one, and the festival next year will be fantastic to really hear what our population needs from these services.
That's really strong, isn't it, in the programme? I sense that from Sheila's contribution as well, around thinking about people as individuals and personalising the care that we provide as much as possible, which is really at the heart of what we're trying to do with an integrated care programme. I just wanted to flip, we're in the last kind of 15 minutes or so, and I just wanted to have a think about winter and coming pressures and just see if people have had a chance to think about my challenge of top tips for the coming months in terms of staying well and living well and keeping safe, really. Maybe Tom, you'd kick us off with your, I'm sure you've got more than 3, but 1 or 2 will do.
It's actually a really good question to start with, and I'm sure that John and I as GPs could go on about this quite a while, a lot longer than 3 points. But I think the key thing is to realise is that as people, as our people who we are honoured to be looking after, and as part of our system, we need to make sure that you have the fundamentals that you need to live and stay well and age well with. So heat, food, warmth, you know, that sort of emotional support, the not feeling lonely. So I think those three things are key, is trying to get through this winter, especially we're not sure what's happening with the Omicron, we're not sure what's going to go through, is having that support that you can access to get those essentials, those day-to-day things that you need for you, whilst you are potentially looking after you're shielding yourself, or you're looking after other people around you. And I've been very sort of privileged to be involved with groups such as Singing for Breathing or other charity groups that are available to actually that provide that online support and that online collaboration for our people, so they're not alone, even if they are stuck in front of a screen at home, making sure that they are safe and making sure that they are well at home. I think that's the exciting thing about it all, David, really, and the team here, is being able to, as a GP, is to be able to, rather than stepping in for a crisis, to be able to say, this is how you can stay well, this is how you can age well and live well, and let's do that together. And that's for the first time in this sort of 20 odd years that I've been in Northampton, that's a really exciting opportunity to get everybody involved in their own care and having that as one system.
Yeah, it's that bottom-up approach that Jean described, and personalised, as Sheila said. Paula, from your perspective, is there something that you think the programme is doing really well that will help people over winter, or do you have a top tip that you think people should think about as they head into the cold months?
So one of the things I think the programme is doing really well, and I think John, echo what John said, you know, I've been nursing in the community for a long time, to 29 years, and it's the first time we've really got all of ourselves together, put money to one side and put the patient at the heart of what we do. And everybody has a real drive to absolutely make a difference, and that's really exciting for me. One of the things I'm really looking forward to is we're going to be starting a remote monitoring virtual hub, where we'll be able to help support people to monitor their conditions and proactively manage people earlier when they start to their observations start to change and they might be deteriorating. So that should start in the winter, and we'll be working to begin with care homes. But that is really, really exciting. I come from a background of admission avoidance, helping people to stay at home rather than go to hospital, and I think that will underpin what we do. But my top tip would be absolutely stay active, keep hydrated, and you know, keep stimulated. My three things: active, stimulated, hydrated.
Those are good, thank you. That remote monitoring is really exciting, you know, giving power to patients and to individuals again to take control over their needs and be able to monitor them in partnership with clinicians where appropriate. So I think that's really, really exciting. What about, Sheila, your top advice for people going into winter, and how you think the programme might help?
Sorry, the phone went and I missed that question.
Don't worry. I was wondering whether you had a top tip for winter and any ways in which the programme might help our residents over the course of the next few months.
Yeah, well, I suppose essentially you need to know the right people to be able to contact. That's some focused person that you can contact to ask for help, and they can signpost you somewhere. Healthwatch can do that, of course. I think as to the eating well, it occurs to me that we know we have these ready meals you can buy, you can have delivered, but I think it's quite a stimulating activity to cook for yourself if you can. So maybe people could be encouraged to think about their diet a bit more and cook what they like. Keeping warm and continuing to exercise. Meeting with your friends, if we can make sure somebody always has somebody that can come in on a friendly basis.
yeah, they're really important. Going back to the points about loneliness and stimulation that Paula mentioned. So yeah, they're really helpful. Thank you, Sheila. Just to close off on the winter top tips, and I've got a few more questions just to finish with. Mark, the question about involvement and people having networks and so on, is there a single point of contact that people can go to where they can get some of that information, a kind of a directory of service, or is it more dispersed in Northamptonshire?
I think it's more dispersed, David, and I think that's one of our challenges going forward, to make sure that we're signposting people where to go for that support and who to access. And I think some of the things that we're putting in place, like the welfare support teams, the work around dementia, some of the other things that have been mentioned, will give people those natural points of access as we go forward, really. So I think they're the key things. We've seen an awful lot of benefit, which I think we already knew, but it's just been even more supported, and that's the power of peer support in what we do going forward. So the opportunity to meet and to be with other people that are experiencing similar things to you, be that managing a long-term health condition, be that being a carer, be that you know, needing a certain set of things. So the support, as well as all the support that we can try and give to each other, there's a tremendous power in the support that people can give to each other, and it also really helps with things like loneliness and social inclusion as well. And one of the last things I was going to say, just in terms of top tips as well, and that's, there's something about kind of making sure that we all continue to work together in the way that we have been. That there's something which links to what you're just saying, David, and that's about supporting each other. And it's just that, you know, it might be that elderly neighbour, it might be those people that you know that are a bit vulnerable in your street. It's just taking those 10 minutes to just say, look, you know where we are if you need us, because that can make a tremendous amount of difference. And I think that was something that has shone through during the pandemic, that those kind of community and personal levels of things have really made a huge difference to people. Thank you.
Yeah, the social capital that appeared suddenly out of nowhere for communities and individuals because of the pandemic, with WhatsApp groups set up on parks and roads, helping neighbours. That's, yeah, if we could find a way of retaining that and building on it. I know our local authority partners are introducing community development workers back into some of our communities, which I think is a really exciting opportunity to do some more of that co-produced community development work. And we've had a question just about the programme and its kind of funding and the Better Care Fund. So that's obviously a national programme of funding for delivering integrated care, but maybe you could say a little bit more about the Better Care Fund and how we're resourcing this programme.
Yes, by all means. So this is funding that it's going through the Better Care programme simply because that is a system, obviously, that brings all health partner contributions, council contributions together in a way that, you know, delivers integrated care. So that's the mechanism we've used. But all the different partners have contributed something. You know, health partners largely have agreed between themselves and the FDs that we would do that and that we needed to invest in it. And we had a very clear case that showed a return as well on that meant we could hopefully continue to invest in it going forward. And the councils have also made some contributions too. So we've put it through that more just as it's a natural place for it to go. Well, we've got a lot of these services that are affected and we might use in future, like community equipment, like district nursing, community nursing, reablement, all those things are in the Better Care Fund. But I'm really pleased that everybody's made the decision as system partners to make that investment and to make sure that we really change this for the good permanently so that we can make it work in future.
Brilliant. And top tip for winter? Staying well over winter?
Oh, well, you know, I think repeating what a lot of people have said, I think as well, the other side of it is staying in touch. You know, contact makes so much difference. Having had, you know, 2 elderly parents, you know, really suffered as well, particularly in COVID with some of the concerns that people have had. So I think that being able to stay in touch with family and friends and finding ways to do that, just to make contact, I think is good for all of us. It's good for your spirit, and it kind of keeps you connected and stops you getting lonely, sort of, and not sharing problems when you should.
Yeah, keeping connected. Jean, I wondered if you, when you mentioned the bottom up, it stimulated some questions online about how we're approaching that, who we're asking, how we're doing that bottom up work, and maybe you could say some about the co-production work we've done in community resilience and so on.
Yeah, so I think at the moment, David, we're very much doing it on a place by place basis. So one of the things that I know Mark mentioned earlier around the dementia work is about getting feedback from people that have been joining those groups and working with us on those, so we can then develop and enhance it and move it forward. So what we're not going to do is just put in one sweeping model across the entire county. What we're going to do is try it in some place. So in a certain place, we're going to ask questions for the people that came. We're going to develop it and move it forward, and then we're going to try it with this enhanced model in the next patch and do the same thing over and over again. So we're constantly learning and adapting and moving things forward. And we also know, which I think is really important, is that just because if something works, say in Corby, that doesn't mean exactly the same model will work in Brackley. We have to make sure that we are tailoring it based on that locality, which is why it's so important that we do this in conjunction with primary care, so because they know their population, they know what their needs are, and we build it up from there. So it's going to be a slowly process, because we think that's the right way to do it, to get it right for the local population.
I agree, and it keeps it sustainable in that way. It's more iterative and in line with people's lives, rather than necessarily a massive revolution. I never get the sense that patients want revolution. They just want good quality services, and that's what we're trying to do with the programme. So that's been a really helpful session. I've got some homework for people who've attended, please. We're obviously thinking about a festival of aging and living well next year. We'll probably have it maybe around summertime, towards May, June. Ideas. We'd love to hear from you. What kind of things would be helpful? Some places have put on hour-long sessions, some have put on longer sessions over a day. So any ideas you have for things we could support you with to help you live well and stay well would be most welcome. And we can then bring them into the programme and have a think about what we do with them as part of a festival of aging and living well next year. The top tips for winter are great. Anybody else who's got top tips that work? And back to Mark's point about networks that are available, where you have networks that are thriving in your local communities, do let us know about them so that we can be in contact with them. And as Jean said, we want to get as granular and as close to individuals as possible. So the more we know about the networks that are available and in your local communities that you use, and that you think we might have some contribution to make to them, let us know, and we'll make sure we get out to speak and see them in due course as the programme develops. So I'll draw a close at that point. I want to say a big thanks to our panelists who've given their time this afternoon to talk this through. This is the first of many. We wanted to meet with you all before the winter season, really, just to get some key messages about what the programme is trying to do, explain what it is. You'll hear the word as we develop the Integrated Care Board over the next coming year. You'll hear about iCAN. We wanted to make sure you knew what it was. And we also wanted to make sure that we have made a start on doing things in the way that we want to continue, which is in partnership and in a co-produced way. So this is one part of that story, and we'll have more of these in the coming months, and we'll look forward to them. So thank you very much, and thank you to the organisers. And I'll look to the panel for any final comments or reflections. No, everyone happy? Good. Okay. All the best. Thank you so much, everyone, for your time. See you again. Bye now.